In this video, I'll be commenting on and also critiquing my routine phacoemulsification technique. So first of all, I should be more centered over the eye, especially for video recording purposes. So that should have been better. Putting in the speculum here, at least it looks like I've got good draping of the eyelashes. Very important to have them out of the way for sterility purposes. Here I'm just putting another drop of topical anesthetic on, a drop of oxybuprocaine, just to make sure that the patient has adequate topical anesthesia before moving on to our incisions. Now I'll be starting with my side ports. I'm using a 1.2mm blade here. First the nasal one and now the temporal one. This is for my bimanual technique. So I could have made the side ports maybe a little bit further into the limbus just to minimize my astigmatism as much as possible. But that was okay. Now I'm injecting some local anesthetic into the eye. This is a combination of 2% lignocaine and a balanced salt solution in a 1:1 ratio. Always important to tell the patient before you do this, otherwise I might get a bit of a fright as it burns. Now I'm going to inject my viscoelastic. Here I'm using a combined viscodispersive, so I'll use a single viscoelastic for both my CCC as well as for my IOL implantation. That was my main wound. I'm using a 2.8mm blade for that. In this theater we have 2.8mm blades, but I actually like the 2.4 more, and then do a wound assisted IOL insertion. So yeah, I'm starting my continuous curvilinear capsulorhexis using a sharp capsulorhexis forceps to initiate the break in the capsule. You can also use a needle, but I find this just saves a step, although the needle is probably more controlled. So aiming for a nice regular 5.5mm CCC centered just nasal to the pupil. Seems like I'm getting a nice regular one here, just using a pull and fold technique. So almost done, just completing it, and there we go, that went nicely. So the next step will be my hydrodissection. I use a flat tipped hydrodissection cannula, and ensuring that we get a nice wave over the posterior surface of the lens, which is shown nicely there. I'm just going to inject a little bit more supranasally just to ensure we've got a really good dissection and separation from the capsule. Then we'll start to try and turn our nucleus. Trying not to put too much force on the zonule. As I see, it's not turning very well. Maybe could have gone ahead and done a hydrodelineation, or maybe just some more dissection, but then it seemed to turn nicely in the end, so that's okay. So then the next step will actually be the phacoemulsification of our nucleus. So for this case, I think I use a division into two hemisegments, and then either a divide and conquer or hemi-flip technique. So it looks like quite a soft cataract going through very nicely with our sculpt settings. Just clearing up the edges a bit for a better view to the back. Now I'll put my second instrument in. Here I'm using a chopper, but it's a blunt tip chopper. I actually really like this chopper from Duckworth in Kent. It's got quite a flat portion on the head, which allows you to put a good amount of force onto the nucleus for rotation, rather than a very small surface area where you end up kind of cheese wiring through between the nucleus and cortex. So this is my go-to second instrument. So yeah, it looks like I'm going for divide and conquer, but then the nucleus seems really soft, so I've switched to a hemi-flip, but I'm not doing a great job here because I'm taking it out from the center. I should be grabbing it at a corner and actually flipping the whole hemi-segment into the anterior chamber. So not a great technique there, but I get away with it because it's a soft nucleus. So now I'm rotating the other hemi-segment, and there again, so I'm approaching it from the proximal corner of the hemi-segment instead of the nasal corner, which would have been better because then you can actually pull it towards you into the anterior chamber. But again, getting away with it just because it's such a soft nucleus. But I would prefer to have used a better technique there. Right, so now just using aspiration, as little phacoemulsification power as possible to take out the epinucleus segments. So that seems to have gone quite nicely, and not too much cortex left, so that should be a pretty quick cleanup. So I don't generally have to inject viscoelastic or more BSS into the anterior chamber to keep it formed between steps if we are quick between steps. But if there's any concern over leaky wounds or posterior pressure or delay between steps, it's a good idea to keep the AC maintained with either BSS or potentially a bit of viscoelastic if you're going towards that step anyway. So here I'm just cleaning up my cortex. I usually like to do a sweep of about 1 to 2 clock hours per aspiration, and that's the most efficient way that I find for cleaning up my cortex. Not much cortex here, so I'm kind of just going for the areas where I see cortex. I generally don't clean up the capsule anteriorly too much unless the patient's planned for vitreoretinal surgery. I just find that it's an additional step with additional time that doesn't add too much value. So now just doing a little bit more cleanup, and then I'm going to swap my hands around and clean up on the nasal side. I really like the bimanual technique. I find that you can get all your cortex, get right out into the periphery, and I just feel a lot safer than with a coaxial aspiration cannula, but that's just my personal preference. So it looks like we've got a pretty good cortical cleanup there. Just have a good look around, make sure there's no little bits hiding away, and that looks good. So here just filling the anterior chamber and the capsular bag with the same viscodispersive viscoelastic. So the next step is to implant our IOL. Here I'm using what appears to be a Alcon C cartridge with a monarch injector, and injecting the IOL into the capsular bag with the leading haptic going in first, and then I'll nudge the trailing haptic and portion of the optic into the capsular bag, just like that. But this IOL doesn't seem to want to open up too easily, and it appears that the trailing haptic is adherent to the inferior edge of the optic here. That may have been not enough viscoelastic or BSS used during the loading of the IOL, so that's something that should be avoided. And here I'm waiting for it to open up, but it doesn't seem like it wants to release on its own, so I'm just going to help it along there just by nudging the haptic off the optic, and luckily it comes free there, so it should open up nicely now into the capsular bag. And just going to use a bit of a rock and roll technique to remove all our viscoelastic from the capsular bag. You really need to rock that IOL to try and get all the viscoelastic out from behind. And then I like to use my infusion, actually blow under the iris, between the iris and the anterior capsule, just to blow out any viscoelastic that may have been stuck there, and then roll my aspiration around the anterior chamber to suck out any viscoelastic that I've then released from that chamber. I find that works well, and I haven't really had problems with retained viscoelastic since I've been using this technique. So now just hydrating our wounds so that we ensure we have a good seal. Luckily these wounds have been pretty stable, so I don't need to hydrate too much, and it appears to be nice and stable. Just a little bit more there. IOL is sitting nice and centrally, so I'm happy with that. So then we'll just give our intracameral antibiotic. I'm using Vigamox 0.1 to 0.2 mils. And we'll normally just check the pressure of the eye, make sure that it feels around about 20 millimeters of mercury, and then our patient is good to go.